Welcome, first-year BHMS students. Let's dive right into today's explainer, covering Chapter 2, Scalp, Temple, and Face. As your professor, I am absolutely thrilled to guide you through the anatomy of the scalp. We're going to build your foundational knowledge layer by layer today. We'll start way zoomed out with the macro boundaries, move down into the microscopic structures, and wrap up with the clinical perspectives that you'll literally be using every single day in your practice.
But before we make our first virtual incision, I've got a question for you to keep in the back of your mind. Why exactly is the scalp's fourth layer known as the dangerous area? I want you to really think about that as we go through the structures today. Because the answer to this isn't just, fun anatomical trivia. It is a profound clinical insight that could absolutely save a future patient's life.
All right, here's our roadmap for this explainer. First, the boundaries of the scalp. Second, the 5 layers of the scalp. Third, the muscles. Fourth, arteries and venous drainage. Fifth, nerves of the scalp. And finally, number 6, applied clinical anatomy.
Okay, Section 1, Boundaries of the Scalp. Let's map out our territory.
If you look at the lateral side of the skull here, you can actually trace the exact edges of the scalp. Anteriorly, it extends right up to the supraorbital margin, so right above your eye sockets. Posteriorly, it wraps all the way back to the external occipital protuberance and the superior nuchal lines on the back of the skull. And laterally, on both sides, the border is clearly defined by the superior temporal lines. So that's our canvas for today. Moving right along to Section 2, the 5 layers of the scalp, the dissection sequence.
Now, medical mnemonics are absolute lifesavers, right? And for this one, the word scalp itself is quite literally the cheat code for the 5 layers. S is for skin, C is for connective tissue, A is the aponeurotic layer, L is loose areolar tissue, and P is pericranium. It's just perfectly designed to help you remember the exact sequence from superficial to deep.
Take a look at how those first 3 layers, the skin, the dense connective tissue, and the aponeurotic layer are tightly bound together. They practically act as a single unit. In surgery, we actually call these the surgical layers of the scalp, or the scalp proper. So if a patient comes in and their scalp has been torn off in a severe injury, it's almost always these top 3 layers that come away together. Going a bit deeper into this cross-section now, look at layer 4. That's the loose areolar tissue sitting just above the pericranium. What's super important here is that this loose layer gives passage to the emissary veins. Think of these veins as literal bridges. They connect the extracranial veins on the outside of the head directly to the intracranial venous sinuses inside the skull. So lock that structural detail into your brain right now. Next up, Section 3, Muscles of the Scalp, specifically the occipitofrontalis. So the occipitofrontalis isn't just one big continuous sheet of muscle. It's actually split into 2 distinct bellies. You've got the frontal bellies up front over the forehead and the occipital bellies in the back. And both of these bellies insert directly into that 3rd layer we just talked about, the epicranial aponeurosis, or the Galea aponeurotica. But here is the kicker. The frontal belly has no bony attachment whatsoever. It just blends right into the skin and muscles around the eyes. Keep that in your back pocket, because it's going to come up again very soon. All right, on to Section 4, arteries and venous drainage. Basically, the plumbing. What you absolutely need to grasp here is this incredibly rich vascular grid. In front of the ear, the scalp is fed by branches of the internal carotid artery, like the supratrochlear and supraorbital arteries, plus the superficial temporal from the external carotid. Then behind the ear, it's supplied by the posterior auricular and occipital arteries, both from the external carotid. These 2 systems freely connect, or anastomose, right over the temple. And running right alongside them is an equally massive venous network. Because of all this blood supply, scalp wounds actually heal incredibly fast. In fact, even completely avulsed portions can often be successfully reattached by surgeons.
Section 5, Nerves of the Scalp. Time to look at the wiring.
Memorizing all 10 nerves on each side of the scalp might seem pretty daunting at first, but it's super logical once you just categorize them by location. 5 in front of the ear and 5 behind the ear. Simple. And in each group of 5, 4 are sensory and 1 is motor. For instance, in front of the ear, you get sensory branches from the trigeminal nerve, like the supratrochlear and supraorbital. The single motor branch there, that's the temporal branch of the facial nerve. Behind the ear, the sensory nerves come from the cervical plexus and dorsal rami, like the lesser and greater occipital nerves, while the motor supply is the posterior auricular branch of the facial nerve. See? It's a beautifully organized system once you just break it down.
And finally, Section 6, Applied Clinical Anatomy. This is the so what, why all of this actually matters to you as future doctors.
Let's break this down layer by layer in a clinical setting. The skin of the scalp is packed with sebaceous glands, which makes it a hotspot for sebaceous cysts. Now, pay close attention to this next part for your clinics. In that second layer, the dense connective tissue, it firmly holds the walls of the blood vessels open. So when these vessels get cut, they literally can't retract and constrict. That is exactly why even a tiny scalp laceration will bleed like crazy. Also, regarding the aponeurotic layer, a scalp wound is really only going to gape wide open if that aponeurosis is cut transversely, which pulls the muscle bellies apart.
And here we go. This circles right back to the question I asked you at the very beginning. The fourth layer, that loose areola tissue, is the dangerous area of the scalp. But why? Because those emissary veins we looked at earlier pass right through it. If a patient gets an infection in this loose layer, that infection can use those emissary veins as a direct highway. It travels straight through the bone and right into the cranial venous sinuses, which can lead to devastating, life-threatening conditions like meningitis.
Now, this brings us to one of my absolute favorite clinical presentations. Remember earlier when we said the frontalis muscle lacks a bony attachment? Well, because of that, if a patient bleeds into that fourth loose areolar layer, say they take a nasty blow to the top of the head, the blood can't go backwards or sideways because of the bony attachments there, but it can pool downwards, right under the frontalis muscle, sinking directly into the soft tissues of the upper eyelids. This perfectly explains why a heavy blow to the top of the head can show up clinically as a bilateral black eye without any actual trauma to the face. It's just fascinating how anatomy works like that.
Before we wrap up this explainer, I have to give a huge shout out and full credit to Dr. Vikram Tripathi, Associate Professor of Human Anatomy at the University College of Homeopathy, Jodhpur. His absolutely exceptional presentation on the fundamentals heavily inspired the content we covered today. Remember, understanding the scalp isn't just rote memorization of layers, it's about seeing these clinical connections. So the next time you see a patient with a black eye, ask yourself, where did the impact actually happen? I wish you all the absolute best in your continued anatomical studies. Class dismissed.